Right, so tonight we are going to talk about muscle relaxants. We have a lot to talk about tonight. So um, oftentimes patients injure themselves, they get into car accidents, and when that happens, there is some type of local damage to either their muscles or what we call the skeletal anchors that are on the muscles. Whenever they have an injury that can lead it can cause them to have muscle spasms and pain. Sometimes it lasts a long time and it can actually interfere with their normal day-to-day functioning, their ADLs, driving, working, stuff like that. Other times it can just be very short-lived. So when we think about abnormalities, we think about muscle spasms, and then we have muscle spasticity. So muscle spasm, these often come from an injury, some kind of injury to the musculoskeletal system. It could be something as simple as just overstretching your muscle when you're working out, or maybe when you're working, or even tearing a tendon or a ligament. These injuries can cause very, very violent, painful, involuntary muscle contractions. Your patients may lay down on the floor, fall down on the floor because they don't, especially if it's in their back, sometimes they don't feel like they can even hold themselves up because the pain is so bad. They'll cry, they'll rock back and forth. It really brings them to their knees. It's when that happens, it's caused by the flood of sensory impulses that are coming into that spinal cord area from that injured area. They go in at such an increased rate that it causes those muscle spasms. Then when we think about muscle spasticity, comes from any kind of damage to the neurons located in that central nervous system. So this could, sometimes it comes from an increase in those excitatory influences or response, or sometimes it's a decrease in inhibitory influences in that CNS region. Sorry, I'm just taking attendance as people are coming into the room. Where was I? Any kind of damage to the central nervous system can also cause that muscle spasticity. The neurons can cause a permanent or sometimes permanent or non-permanent state of where those muscles are just completely having spasticity issues. So we consider those sustained muscle contractions where they just continuously happen, no matter what kind of medicine we give them, it still is going to continue to happen. The medicine will decrease them so they're not as noticeable, but they are a sustained continual muscle contraction. And then because of that muscle spasticity, it will cause over time, it's going to result in a loss of nerves that will help maintain balance or controlling that muscle activity in that actual muscle area, depending on where it is. So we give skeletal muscle relaxants to help with both of these situations. They do have some adverse side effects, so it causes drowsiness. So you want to think about when you're given these medications. So right now, I'm thinking about a typical pain management patient who maybe has been in a severe car accident and they have a lot of chronic ongoing pain that's not managed just by their primary care physician. So they actually have to go to a pain specialist because they require a higher level of medication, one, because their pain is so bad, and two, because they're building a tolerance to it. And regular primary care offices don't specify in that, so they'll go to pain management. So when we're treating these patients, we're treating them for pain and skeletal muscle issues. So they're often on more than one type of medication. So they could be on a narcotic and a skeletal muscle relaxant. So you want to think about those patients when you're giving them their medications, because all of these medications have these adverse reactions that we see: drowsiness, fatigue, It's going to make them weak. It could make them confused, depending on their kidney function or their liver function and the medication that they have. It can cause headaches and nausea. The headache and nausea I don't worry about, but when you're also giving them in conjunction with narcotics or opioids, they're going to have that effect times 2, because both of those medicines cause drowsiness. Both of those medicines cause fatigue. So it's just something to think about. And if you have a patient that has low blood pressure in the morning and you check it, you might not want to give these medications together. You might want to educate him and say, your blood pressure is low right now. We're going to hold both of them, or we're going to give you one and I'll recheck you in 2 hours, and then we'll see about giving the other one. Because you don't want to drop their blood pressure and their respiratory effort, and then they go into respiratory failure. So then drug-to-drug interactions would be any other drugs that call any other CNS depressants, because they're all going to have that same effect. So narcotics, narcotic antagonists, and anti-migraine agents. So this is actually in your book. It's figure 26.1. This is a nice little picture of the neural pathways of pain and how pain is transmitted in the human body. I will let you read about that. I'm not going to quiz you on that, so you can take a look in your book. So how do narcotic agonists work? So they are drugs that react with opioid receptors throughout our body. They work to cause an analgesic effect, sedation, or euphoria. So because there's a potential for the development of physical dependence while patients are taking these drugs, these narcotics are classified as controlled substances, because there's a very high likelihood that someone could become physically dependent on these medications. They are also used as antitussives and as adjuncts to general anesthesia to produce rapid anesthesia, sedation, and respiratory depression. So you'll see sometimes a patient will go off to have a procedure and they'll call you and say, the patient had 2 milligrams of Versed and a dose of Dilaudid. So sometimes they'll give it with that general anesthesia to help that process along, because they're all CNS depressants and they reduce that respiratory depression. And sometimes if they're doing a procedure where they're expecting that they're going to be in pain, then they give that medication to them so that when they wake up, they're not feeling that high influx of pain, depending on whatever procedure they had done. Indications for giving someone a narcotic agonist would be to relieve their severe acute pain, or like we said earlier, chronic pain, any kind of preoperative medication, or analgesia during that anesthesia. We want to make sure that we're always giving the accurate calculation of the dose required, because we don't want to overdose our patients. Usually in the hospital settings, I don't know how it works in long-term care, but in the hospital settings, you have to count these medications in the AccuDose before you pull them, because they don't want anyone to steal them. And then when you give a patient, say you have an order to give 2 milligrams of IV Dilaudid, but the medicine only comes in 4 milligram vials. So you're only going to give half of it. So you have to account for the other half that you have. So you would have to have another nurse witness you. So if you have anything to waste, you have to make sure you show it to another nurse, and you both have to waste it in the computer. And then you have to make sure you count it. So a good rule of thumb is if you have to count it when you pull it out, then you always have to waste it. It's good to remember it like that. When you are trying to decide what narcotic to use in a particular situation, it's always important to consider all of the aspects of the patient's condition, so that you can make sure that the drug is going to be the most effective in each situation. And you want to minimize the side effects. You want to have the fewest adverse effects for the patient, but you want to be able to manage their pain. You have to remember that every patient is different, and his or her response to that medication is also going to be different. So when we give these medications, the intravenous IV administration is always the most reliable, because we can achieve therapeutic levels. We can also do intramuscular and subcutaneous, which offers different rates of absorption. Absorption rates tend to be slower in female patients compared to males, because of the normal fat content of females' muscles and tissues. These medications also go through your liver for metabolism, and they are excreted in your urine and your bile. There's a lot of different medications, so their half-life periods are very different depending on the medication, and most of them cross the placenta and are known to enter breast milk. So you would want to avoid narcotics if there is a presence of any known allergy to any narcotic agonist, because you don't want to have a hypersensitivity reaction. If there's been any, the patient has any diarrhea caused by toxic poisons, because it depresses the GI activity, which could lead to an increased absorption and toxicity. So remember, we said that these narcotics depress everything. And when we use them for anesthesia, they depress everything. So it's going to slow down your heart rate, your GI motility, your excretion, everything goes to sleep. So that's why you would want to avoid it with that diarrhea, because all that GI activity is going to be depressed. And then you would want to use under a doctor's care if they're pregnant, in labor or lactating, because of the different effects that it can have on the baby. We want to use cautiously in patients with respiratory dysfunction, because we know that these medications depress the respiratory system. So if they already have respiratory issues and they're not able to get in good oxygen, then narcotics is probably not the best choice. Because it's going to exacerbate that respiratory issue. You want to be careful with recent GI or GU surgery or any kind of acute abdomen or ulcerative colitis, because of the GI depressive effects of the narcotic. It's going to slow everything down. Most frequently seen adverse effects are associated with the effects on the various opioid receptors. So that's going to be your respiratory depression with apnea, that's periods of not breathing, and then cardiac arrest. So adverse reactions, we can see shock, which can be caused from narcotic-induced respiratory center depression. We can see orthostatic hypotension. We're going to see those GI effects such as nausea, vomiting, or constipation. So if you know that your patient is had a recent hip surgery and they're going to be on narcotics, you should always make sure that the doctor puts on a stool softener. They need to be on some kind of stool regimen, because constipation is one of the biggest side effects we see. It can also cause biliary spasms, which can cause vomiting, kind of violent periods of vomiting. We can see neurological effects, such as the patient can say their lightheadedness, they can complain of dizziness, you might see psychosis, especially in our older patients. We have to use narcotics very, very, very carefully in our older patients. It can cause anxiety, it can cause fear, it can cause hallucinations, pupil constriction, and then impaired mental processes. So when narcotic agonists are given with barbiturate general anesthetics, or with some phenothiazines, which are medications that are used to treat certain mental disorders such as schizophrenia, and then also when patients are taking those MAOIs, the likelihood of respiratory depression, hypotension, and then sedation or coma is also increased, because all those medications work on CNS. So narcotic agonists and antagonists, they act at a specific opioid receptor sites in the central nervous system to help produce analgesia, sedation, euphoria, and hallucination. So some of the medications that you guys will see are buprenorphine. Another one is Stadol. So buprenorphine we give that for mild or moderate pain. Stadol, we use that preoperatively before they go in to have surgery. It helps to relieve moderate to severe pain. And then we have something called Nubain. So Nubain, actually, we use this for patients that have moderate to severe pain. Sometimes they use it in conjunction with general anesthetic to help move the process along. And then sometimes pregnant moms will get this to relieve pain during labor and delivery. So narcotic agonists, antagonists, stimulate certain opioid receptors, but block other receptors. So these drugs have a less abuse potential than the other pure narcotic agonists. They exert a similar analgesic effect, such as morphine, but like morphine, they may cause sedation, it's going to cause respiratory depression, and then constipation. They have also been associated with more psychotic-like reactions. So morphine is something that we hardly ever give to older adults. I have seen it used, but it's usually used as a last resort because that's the population of people that it really tends to produce those psychotic events with. And they may even induce withdrawal syndrome in patients who have been taking narcotics for a long period of time. So these drugs have three functions. They're going to relieve that moderate to severe pain. They are going to be an adjunct to general anesthesia, and they will relieve, this is the medications that we will give to relieve pain during labor and delivery. They are readily absorbed after intramuscular administration, and they will reach peak levels rapidly when given IV. One of the other things you want to think about, I don't know that you guys give, I don't think LPNs do IV push at all. So that's nothing, or maybe you can't give the first one. I think it's that you can't give it the first one. I'm not sure, I have to clarify that. It's either that you can't do it at all or that you just don't give the first dose. These medicines are metabolized in the liver and are excreted in the urine. So you're going to use carefully in those patients who have kidney and liver issues. They are known to cross the placenta and enter breast milk, so they have to be used very carefully. They're contraindicated in the presence of any known allergy, obviously, because you want to avoid that hypersensitivity reaction. They should be used during pregnancy only if the benefit to the mother outweighs the risk to the fetus, because it causes respiratory depression. They use it more so during labor and delivery because it is just a very short-term exposure to the fetus. And then you would want to educate the mom about not taking any type of medicine like this when they are breastfeeding. So caution should be used in cases of physical dependence because withdrawal symptoms can be precipitated. We should also be use caution with patients that have chronic obstructive pulmonary disease or other respiratory dysfunction, because these, again, they act on the CNS system and they cause respiratory depression. So if they already have problems breathing, this is probably not the ideal medication, or they have to be closely monitored when we do it. We also want to use cautiously in patients who are having MIs. An MI is the nursing term that we use for an acute myocardial infarction. It's a heart attack, but that's how we say it. My patient had an MI. Any documented coronary artery disease or hypertension, because the cardiac stimulatory effects of these drugs can be exacerbated. Let's see. So adverse reaction: headaches, dizziness, psychosis, anxiety, hallucinations, ureteral spasms, and urinary retention. I have seen that a few times in our older population. Doesn't mean it can't happen to anyone, but the hallucinations, the psychosis, the urinary retention, very common in that older population. When they are given with barbiturate general anesthetics, the likelihood of respiratory depression, hypotension, and sedation or coma greatly increases. If this combination cannot be avoided, if this is what the patient has to have, then you would want to monitor these patients very closely, and then you want to make sure that you're given the appropriate supportive measures. So if they have low blood pressure, you're going to give them medications probably to bring the blood pressure up, maybe IV fluids to help increase that fluid volume, things like that. That's what we consider supportive care. Narcotic antagonists, some of these medications, there's one called Revex. This reverses the effects of narcotics. We use this if a patient is known to be, or we have a suspected narcotic overdose. We have naloxone or Narcan, which most of you have probably heard of. This reduces the adverse effects of narcotics. We're going to use this if the patient has a suspected narcotic overdose. And then we have one called naltrexone, which is used in the management of alcohol or narcotic dependence. So Narcan is the one that we see in the hospital. It's the one that we give. I have given Narcan to a patient before. If a patient is ever on a medical surgical floor and you think they've overdosed, maybe because of the medicines you gave them or because they're taking, sometimes the patients take their own medication, which is what happened in the case of my patient. I was giving her IV Dilaudid. Her sister brought in her purse. She had pills of Dilaudid in her purse, and she was taking them because her pain was bad. And then when I went to check on her after lunch, she had like her respiratory rate was 4. So she had to get Narcan. It worked I had to actually give her 2 doses. Usually it works with 1 dose. Sometimes, depending on how bad it is, it's 2. And they wake up right away. Like you push it and within like 10 seconds, they wake up, and they are very angry when they wake up, especially if they're addicted to the drugs, because it kills their high almost instantly. So they're usually not very happy with you. They do have to go and stay in the ICU if you ever use them. If you ever use these medications on her, or on anyone, they have to be monitored at a higher level of care for at least 4 hours afterwards. So narcotic antagonists are drugs that bind strongly to opioid receptors, but they don't activate them. So they bind to them, but they don't activate them. They block the effects of the opioid receptors and are often used to block the effects of too many opioids in the system, in a patient's system. They are indicated for the reversal of the adverse effects of narcotic use. Those adverse effects that we see are the respiratory depression and sedation. The narcotic antagonists do not have an appreciable effect in most people, but individuals who are addicted to narcotics experience the signs and symptoms of withdrawal when receiving these drugs rapidly. So if it just happened by accident, or maybe you gave them too much, or maybe they were at home and they took too much one time by mistake, they won't notice those effects as much as someone would that's addicted to drugs. And like I said, they're going to be very angry when they wake up. All right, so pharmacokinetics. So these narcotic antagonists may be administered parentally. What does parentally mean?
IV.
Very good. IV or orally. I've also seen, sometimes they will drill, like the EMTs will drill into the bones. If they can't get it through the nose, they will drill into their bones and they can administer it that way. I've heard of it done in our hospital once where they had to drill into the patient's bone. They are well absorbed after injection and are widely distributed throughout the body. They do undergo hepatic metabolism and are excreted in the urine. So again, you're going to watch out for those patients with kidney and liver issues. They do enter the breast milk. They're contraindicated in any known allergy to avoid hypersensitivity reactions, and you should use them cautiously during pregnancy and lactation, obviously because of the adverse effects on the baby, and with narcotic addiction because of the precipitation of a withdrawal syndrome. Adverse reactions, tachycardia, hypertension, dysrhythmias, and a feeling of anxiety. The most common effect is what they call an acute narcotic abstinence syndrome. And this is withdrawal. And this is characterized by nausea, vomiting, sweating. So we talked earlier, a couple weeks back, about different medications that we gave for patients that were addicted to alcohol. So patients that are alcoholics that stop drinking can actually die when they're going through withdrawal. Opioids, heroin, things like that, Dilaudid, they're not going to die. They're going to be extremely sick and they're going to look like death, but they won't die. So you're going to see that nausea, they're going to be sweating, they're going to be vomiting, they're going to be very weak, they're not going to be able to get up, but these are the patients that are addicted to it. And you really need to educate yourself and know how to treat these patients because you're going to see a lot of these patients in the clinical settings, especially in the hospitals. All right, so categories of anesthetics. So we have general anesthetics and local anesthetics. Anesthetics are drugs that are used to cause complete or partial loss of sensation. General anesthetics are central nervous system depressants used to produce a loss of pain, sensation, and consciousness. Local anesthetics are drugs that are used to cause a loss of pain, sensation, and feeling in a particular area of the body, but they don't have those systemic effects associated with the severe CNS depression. The goals of general anesthesia. So this involves, general anesthesia involves the administration of a combination of several different general anesthetic agents to achieve analgesia, which is the loss of pain perception, unconsciousness, or is the loss of awareness of one's surroundings, or amnesia, which is the inability to recall exactly what happened. So usually these drugs are combined to achieve the best efforts with the fewest adverse side effects. So it's going to depend on the patient's status, how healthy they are, what kind of contraindications are in place based upon their chronic health issues and exactly what they're having done. And then the anesthesiologist will decide what is the best type of anesthesia to give the patient. So risk factors associated with general anesthetics, they cause widespread CNS depression. And obviously it comes with a risk. That's why they say you should never have general anesthesia unless it's something that's necessary, that you shouldn't do elective procedures because they're not safe because they come with a risk. So those CNS factors that we want to think about, so any patient that has an underlying neurological disease, so epilepsy, history of stroke, myasthenia gravis, any kind of neurological disease that represents a risk for an abnormal reaction to that CNS depressing effect or those muscle relaxing effects. Cardiovascular disease, coronary artery disease, hypotension. These put patients at risk for severe reactions to anesthesia, so it has to be used very carefully. It can cause hypotension, it can cause the patient to go into shock, it can cause cardiac dysrhythmias, any respiratory factors, so patients that have obstructive pulmonary disease, so your COPDers, your chronic bronchitis, your asthma patients. This is why they ask you if you have been sick recently with any kind of upper respiratory infection. And this is why when you go under anesthesia, they want to know if you've had any respiratory infection. They do an EKG and they make you have a little physical with your doctor because when they want to make sure that you don't have any of these issues. So any kind of respiratory issues can cause that delivery, can complicate that delivery of gas exchange. Some patients have to be intubated shortly for a small time period during the time they have their surgery. So if they're having respiratory issues, that can cause a problem. And then your patients with renal and hepatic function issues, because again, that's going to interfere with that metabolism and excretion. So patients that have hepatitis, renal failure, things like that. So agents used in balanced anesthesia. So there's a wide variety of drugs available, and the therapeutic effects that we see, they need to be balanced because of the potential for those adverse effects. So we consider this balanced anesthesia. So this is the combining of several different drugs. Each drug has a very specific effect. The goal was ultimately to achieve analgesia, muscle relaxation, unconsciousness, and amnesia, rather than just using one drug. So sometimes you'll see these are your preoperative medications. So they're going to get maybe an anticholinergic to decrease certain secretions that can help facilitate intubation if they have to be intubated, and prevent their heart rate from dropping during surgery. They might get a sedative to help. Sometimes different sedatives can cause amnesia. Sometimes it just helps relax the patient. Sometimes we give antiemetics, which decrease nausea and vomiting because we slow that GI activity. Some certain anesthesias that we give cause patients to vomit, sometimes during anesthesia and sometimes after. Obviously, we don't want them to vomit during the procedure because then they can aspirate and they can get pneumonia. Sometimes we give antihistamines because we want to decrease the risk of any allergic reactions, and it also helps to dry up the secretions. And then we give narcotics to help aid with that analgesic and to cause sedation. So some of the medications that some of the general anesthetics that we use, the ones that you'll see in the hospital, the main ones, we use ketamine. Ketamine has a very fast onset, but it also causes a very slow recovery. So it takes them longer to come out of it. We also use propofol. It's also called Diprivan. Propofol they use all the time in the ICUs and during surgeries. It's very short acting, but it has a very rapid onset. So they use it for very short procedures like colonoscopies, endoscopies, things like that. It can cause bradycardia and hypotension, obviously. There's another one, midazolam. That's one that I've seen used in the ICU. That one is more likely to cause nausea and vomiting. These are all in your book if you want to look them up. Midazolam also works very, very quickly, but you don't see the peak effects to 30 or 60 minutes. So this is not a medication that you would want to use for a colonoscopy or an endoscopy because the procedure is so quick, it wouldn't work in time. Those procedures usually take about 10 minutes, 15 tops if they're doing both. General anesthesia is delivered by a physician or a nurse anesthetist, which they go through extensive training. They know how to deliver these drugs, along with intubating their patients, delivering mechanical ventilation, and offering full life support. They depress the RAS system and that cerebral cortex. They produce sedation. They cause hypnosis, anesthesia, amnesia, and unconsciousness, so that way the doctor can perform the painful procedures that they are having done, depending on what they are. They are lipid soluble, so they are distributed widely throughout the body. They are metabolized in the liver, and they cross the placenta. They also come with adverse reactions, so circulatory depression, hypotension, shock, decreased cardiac output. It can cause certain arrhythmias, that respiratory depression, headache, nausea, vomiting. It can also cause malignant hypothermia. It's a very rare condition, but it is a dangerous reaction to anesthesia. So this happens when there is all of a sudden a big spike in the body's temperature. Because the temperature gets so high and it happens so fast, the patients usually get very, very stiff muscles. And then they have to actually treat the malignant hyperthermia with a different drug to help relieve the symptoms until the syndrome stops and the medication wears off. So drug-to-drug interactions, ketamine and halothane can cause cardiac issues. Combination of barbiturate anesthetics and narcotics are more likely to cause apneic episodes in patients than with other medications. So apneic, that's that period where people stop breathing. And then the midazolam that we talked about is associated with increased toxicity and length of recovery when they are used in conjunction with any kind of inhaled anesthetic. So sometimes they'll give you something over top of your nose that has a gas that you breathe in that puts you to sleep. So that would be if you use midazolam with any of those, increased toxicity risk, and then a longer recovery time in that recovery room to wake up. So if we're giving local anesthetic, this is going to refer to a loss of sensation in limited areas of the body. We can achieve local anesthesia by several different ways. So we can put a topical administration on. So this involves the application of some type of a cream, a lotion, an ointment, a drop of a local anesthetic to the skin to help relieve pain. We can also apply these forms of local anesthetics to the mucous membrane. So we can do them in the eye, in the nose, in the mouth, in the urethra, the anus, and the rectum to help relieve pain, and to anesthetize a certain area to maybe for a certain procedure. Systemic absorption is very, very rare, but it can occur like with topical applications. If you have a skin breakdown somewhere and you would put that medication on that open area, then you risk systemic absorption. Then we have infiltration, which is local anesthesia that involves injecting the anesthetic directly into the tissues to be treated. So sometimes if we're doing sutures, we'll put a needle with some lidocaine in it right inside that open area that needs to be sutured to make it numb. We have to go deep into the open area wherever it is because we want to get down to those nerve endings. And you want to prevent them from sending those nerve impulses to the brain. So that's why they go around the area and they also go into that area so they can get those nerve endings. Then we have what's called a field block. This involves injecting the anesthetic all around a specific area that's going to be affected by, that you're going to have a procedure or a surgery one. It's more intense than infiltration because the anesthetic agent comes in contact with all of the nerve endings surrounding that area. This type of medication you would usually see with a tooth extraction. Then we have nerve blocks, which are local anesthesia that involves injecting an anesthetic along the nerve or nerves that run to and from the region in which the loss or the pain sensation or muscle paralysis is needed. Sometimes they do this with cesarean sections. And then we have IV regional anesthesia. So this involves draining, I've never seen this done, draining all of the blood from a patient's arm or leg. They secure a tourniquet to prevent the anesthetic from entering the general circulation, and then they inject the anesthetic into a vein of the arm or the leg. And they use this for certain specific surgical procedures. So this is the mechanism of local anesthesia and how it works. You can look at that, that's in your book. So local anesthetics, they work by causing a temporary interruption in the production and conduction of those nerve impulses. If the nerve impulses can't get through, then you can't feel the pain. They affect the permeability of the nerve membranes to different sodium ions, which usually those sodium ions infuse into the cell when there's any type of stimulation. But this prevents that whole process from happening. You prevent the sodium ions from entering the nerve, then they stop the nerve from depolarizing. Let's see. Nerve impulses are directed towards the section that are lost and then actually what area they go to. Local anesthetics are indicated for infiltration, anesthesia, which we talked about on the previous slide. Also for your peripheral nerve blocks, your spinal anesthesias, and then sometimes for just the relief of local pain. Sometimes patients that have chronic back pain will go in and they'll have procedures where they get like a local block to try and give them some relief, and they'll try and deaden off nerves to try and stop the pain. That's considered part of pain management. And then, let's see. Oops. I moved my slide, sorry guys. All right, so they're broken down immediately into the plasma. They metabolize slowly in the liver. Contraindications would be any known allergy to this medication because it can cause a hypersensitivity. If patients have heart blocks, we would not want to use this medication because it can exacerbate with systemic absorption and cause shock. Let's see, they should be used during pregnancy and lactation only if the benefit outweighs any potential risk to that fetus or that neonate. You also want to use very carefully in patients that have decreased plasma esterases because this can result in toxic levels of those ester type local anesthetics and it can increase the effects. which can be harmful. Effects that occur are going to be on that CNS system. So you're going to see headaches. These are very, very common with your spinal anesthetics and your epidurals. So sometimes patients will go off the floor and they'll have an epidural, or maybe they're having a baby and they have an epidural, or they'll have some kind of a spinal procedure and they'll have an epidural. And then when they come back to your floor, they have to lay flat for a certain number of hours, usually 1 to 2 hours. They keep them flat, sometimes up to 4, depending on the procedure and how much of the epidural. Because if you sit them up, then they can have a bad headache. That's very, very hard to manage. They might be restless, they might have anxiety, they might be dizzy, they can have tremors, blurred vision, backaches. That's a side effect of the spinal anesthetics and those epidurals. You're going to see some GI issues, so they might have nausea and vomiting. It's also going to show cardiovascular effects, so you might see peripheral vasodilation, myocardial depression. You might even see some arrhythmias, blood pressure changes. All of those can lead to cardiac arrest or respiratory arrest. So you need to use them very carefully. When giving local anesthetics and succinylcholine together, it can cause an increased and prolonged neuromuscular block. There's also less risk of systemic absorption and increased local effects when you combine these drugs with epinephrine. Introduction to the autonomic nervous system. So this should be a little bit familiar from Anatomy and Physiology and Biology 110. You guys learned about this stuff. The autonomic nerve system is the location of the main nerve centers for the autonomic nervous system. You're going to have your hypothalamus, your medulla, and your spinal cord, all three of those. The definition is involuntary or visceral nervous system. That's what the autonomic nervous system is, the function. So sometimes you'll hear us say the ANS or the autonomic nervous system, or it's used interchangeably and called the involuntary or visceral nervous system. More often than not, it's called the autonomic nervous system. Some of the old school nurses and doctors still will say involuntary, but I don't hear it that often. So these functions with our patients have little conscious awareness of any activity that's happening, so they don't really notice them as well. The autonomic nervous system works closely with our endocrine system. It helps regulate and integrate the body's internal functions with a relatively narrow range of normal on a minute-to-minute basis. So it's regulating things to keep everything in a normal range, and it actually does it. It's continuous. It's ongoing. The ANS integrates parts of the central nervous system and the peripheral nervous system to automatically react to any changes in that internal and external environment. So what body functions are regulated by the autonomic nervous system? It regulates our blood pressure. It helps regulate our heart rate. It determines our respirations. It regulates our body temperature, our water balance, our urinary excretion, and our digestive function. So it does a lot. The autonomic nervous system is further divided into two branches. We have the sympathetic nervous system, or the SNS, or the parasympathetic nervous system, the PSNS. They are different. They basically differ in 3 different ways. The location of the originating cells in the CNS is going to be different. The location of the nerve ganglia is going to be different. And then those preganglionic and postganglionic neurons are going to be different.
Ms. Davis.
Yes.
You had to change the slide.
I'm sorry. You're right. I forgot. So I'll leave this up for a second. So yes, so it's the ANS has 2 branches, the sympathetic and the parasympathetic. The difference between these 2 branches is these 3 things: the location of the originating cells in the CNS, the location of the nerve ganglia, and the preganglionic and postganglionic neurons. Those are the three differences. So figure 29.3 in your book shows you the fight or flight response to the sympathetic stress reaction in our bodies. So it basically takes your ACTH, a lot of different hormones, antidiuretic hormone. It affects your blood pressure, your GI, your respiratory rate, your pulse, all those sympathetic nervous system responses. You can take a look at that and you can see how that system works. We're going to talk about it a little bit further here. So what happens when we activate our sympathetic nervous system? When stimulated, the sympathetic nervous system works in conjunction with that endocrine system to prepare the body to flee or to turn and fight. That's why we call it the fight or flight. Our cardiovascular activity increases. So if our cardiovascular activity increases, so does our blood pressure, our heart rate, and our blood flow to all those skeletal muscles. Our respiratory efficiency also increases. Our bronchi inside of our lungs dilate so that we can move more air in with each breath that we take, and then our respiratory rate increases. Our pupils are going to dilate because we want to get more light into our eyes to help improve our vision in darkened areas, which helps a person to be able to see in order to fight or flee. Our sweating increases because we want to dissipate the heat that's generated by that increase in all that metabolic activity that we just talked about. We'll see piloerection, which is the hair on our arms will stand on end. Stimulation of the CNS causes our blood to be diverted away from our GI tract because there's no real need for it to be there during that time. So when we're in that fight or flight mode, we're really not thinking about eating or digesting food, so we can divert that blood flow from the GI tract to somewhere else in the body where it's needed. So it's not common to see our bowel sounds decrease and our digestion slows dramatically. Our sphincters are also going to be constricted, and then bowel evacuation is less likely to occur. So blood is also diverted away from internal organs, including the kidneys. When that happens, it results in activation of what we call the renin-angiotensin system. I don't expect you guys to know about that right now. We're going to talk a lot about it next semester. You're going to know it in and out. It activates that system, and then we have a further increase in blood pressure and blood volume as water is retained by the kidneys. Our sphincters and our urinary bladder are also constricted, so our urination is decreased. So, results of PSNS stimulation, the parasympathetic nervous system. So we are going to see so the parasympathetic nervous system works in opposition of the CNS. So this allows the autonomic nervous system to maintain a very fine control over the homeostasis internally inside of our body. So the SNS increases heart rate while parasympathetic system decreases. So it does the opposite. The ANS can influence our heart rate by increasing or decreasing that sympathetic activity or increasing or decreasing parasympathetic activity. The CNS is associated with the stress reaction and then that expenditure of energy. The parasympathetic system is associated with activities that help the body store and conserve energy. So they work opposite. So adrenergic agonists, what are they? An adrenergic agonist is also called a sympathiomimetic because it mimics the effects of the sympathetic nervous system. The therapeutic and adverse effects associated with these medications are related to that stimulation that we're going to see on the adrenergic receptor sites. The use of adrenergic agonists vary from ophthalmic medications. So for the eye, we use these to dilate the pupils, all the way to systemic preparations that are used for patients who are experiencing shock. We can use these medications for patients of all ages. So this is figure 30.2 in your book. It's in chapter 30. This is just going to show you the physiological responses you're going to see when we give a patient an adrenergic agonist. What are we going to see in the body? We're going to talk about some of those, so you can go look at that slide if you would like. So some of the medications that we give. So we give epinephrine, also known as adrenaline. So we would give this in patients that have shock. Sometimes we will give it to patients to treat glaucoma. And then sometimes we add this to prolong the effects of any kind of regional anesthetic that we give. We also give norepinephrine. You're going to hear a lot about that, also called Levophed. So we use this to treat shock or during cardiac arrest because we want to get that sympathetic activity back. We use dopamine. Dopamine is also used to treat patients in shock. We use dobutamine for congestive heart failure. Aramine is another drug that we use. It's a synthetic agent that is very similar to norepinephrine, so we use it during shock or cardiac arrest. All these medications are in your book. You can look at them. I just try and pull out the ones that you guys are going to see in the clinical setting. So drugs that are generally those sympathomimetics are called the alpha-agonists. They stimulate alpha receptors. Then we have beta-agonists. They stimulate beta receptors. So there's the alpha-agonists and the beta. Each one stimulates the, one does the alpha receptor, one does the beta receptor. Let's see. So the agents that affect some medications will stimulate just one. Some medications will stimulate both at the same time. So a medication that would stimulate both the alpha and the beta would be that dobutamine that we talked about, the dopamine and the ephedrine and the epinephrine. Also the norepinephrine or the Levophed that we talked about. So these, how does it work? The effects of the sympathomimetic drugs are mediated by those adrenergic receptors in those target organs. So the reason that we're giving the medication, where are we trying to achieve some type of an effect? So it's going to increase the heart rate because it's going to increase that myocardial contractility. So if we are giving it to a patient that is in cardiac arrest, their heart's not beating anymore, that would make sense, right? We're going to try and increase that. We want that heart to start contracting. So that's why we would give them that medication. We want it's going to dilate the bronchi, and then it's going to cause the respirations to increase in rate and depth. It's going to cause blood vessels to constrict. It's going to cause an increase in blood pressure. It can also cause intraocular pressure to decrease, which is why we give it to patients who have glaucoma. And then it causes glycogenolysis. I'm sure you guys remember that from biology. It causes the breakdown of glucose stores in the body so that the glucose can be used as energy. So it's going to cause our pupils to dilate, and it's going to cause us to sweat. It's going to cause our sweat to increase. These drugs are generally indicated for the treatment of hypotensive states, shock, any kind of bronchospasm, or even some certain types of asthma. So they are rapidly absorbed in the system after they're injected, or they pass through the mucous membranes, depending on how they're delivered. They're metabolized in the liver, and they are excreted in the urine. So contraindications for taking these medications, any patient that has any kind of tachyarrhythmia or ventricular fibrillation, because these medications are going to increase the heart rate and our oxygen consumption already. So it's going to exacerbate these conditions. If a patient has hypovolemia, so hypovolemia is, this would be for which fluid replacement would be the treatment for associated hypotension. So not necessarily because they had hypotension because they were in shock. Hypovolemia is a different type of low blood pressure. And then you have halogenated hydrocarbon general anesthetics. So this is just another anesthetic that some anesthesiologists use to produce that that effect where you're completely out and you lose consciousness and have amnesia. So these anesthetics, when you use with these agonists, will cause issues in the myocardium of the heart, and it can cause serious cardiac effects. It could cause VFib, VTAC, things that could be life-threatening. And then you want to use carefully with patients who have peripheral vascular disease because it can exacerbate that systemic vasoconstriction. And then adverse reactions. So we're going to see arrhythmias, hypertension, palpitations, angina, dyspnea. What's dyspnea?
Is that breathing? Breathing.
Difficulty breathing, shortness of breath, yes. You can see nausea and vomiting, headache and sweating. And then you want to be careful with your tricyclic antidepressants and your patients taking MOIs because it can have an effect on the blood pressure and the heart rate. So now we have our alpha-specific adrenergic agonists, or alpha agonists, they call them. So these are drugs that bind primarily to the alpha receptors. Remember, we said in the last slide that some medications bind to the alpha and the beta. These only bind to the alpha. Drugs in this class that we're going to talk about would be phenylephrine, midodrine, and clonidine. Clonidine also, you might see it as catapres in the clinical setting. So alpha-specific adrenergic agonist or alpha agonist are drugs that bind primarily with those alpha receptors rather than the beta. The therapeutic effects are a result from that stimulation of the alpha receptors located in the CNS. Indications for use would be hypertension, constriction of topical vessels in the nose. These drugs are generally well absorbed from all routes of administration, and they show peak levels in a very short period, usually 20 to 45 minutes. They are widely distributed in the body. They're going to be metabolized in the liver and then primarily excreted in the urine. Contraindications. Obviously, you wouldn't want to use in the presence of an allergy to any of these specific drugs because you're going to cause that hypersensitivity reaction. You can see severe hypertension or tachycardia because of the possible additive effects. You would not want to use with patients that have narrow angle glaucoma because it can be, that condition can be exacerbated because it can cause arterial constriction. It says in your book that there are no adequate studies about using during pregnancy and lactation. So each case, each person's case should be reviewed as a, case-by-case basis, and the doctor should obviously only use if the benefit to the mother outweighs the risk. You should use cautions in the presence of a patient that has any kind of cardiovascular disease or vasomotor spasms because these conditions can be aggravated because of the vascular effects of the drug. Thyroid toxicity, this is a condition that's caused by when you have excessive buildup of quantities of different thyroid hormones. You also want to use cautiously in diabetes because the thyroid stimulating and the glucose elevating effects are are exaggerated. You want to use cautiously in renal and hepatic patients, obviously because of the metabolism and excretion of the drug. Adverse reactions, anxiety, restlessness, depression, fatigue, blurred vision. You might see ECG changes. So you might see arrhythmias on an EKG. You might see blood pressure changes. Maybe they could be nauseated, have some vomiting. You might see decreased urinary output. You want to use cautiously with patients that have those MAOIs and TCAs because of the cardiovascular effects. And then you want to use carefully with digoxin and beta blockers because of the effects on the heart rate. So our beta-specific adrenergic agonists. So these are the ones that work just on the beta sites. We use this for treatment of shock. So one of the medications we use, you'll see it as Isuprel, ISUPREL, Isuprel. We use this only in emergencies, but you might see it if you're in the emergency room or in an ICU. So we use it to treat shock. We use it for certain heart blocks in transplanted hearts. We use it for the prevention of bronchospasm during anesthesia. And then we use it as an inhaled form to treat bronchospasms. Another time that you might see it is if you are a labor and delivery nurse, we use a medication called Ritodrin, which helps manage preterm labor. And then we use it, one of the most common medications that you guys have probably heard of is albuterol or Proventil or Ventolin. So this is going to be used, these are our inhalers to help with those, to relieve those bronchospasms. Most of the drugs that belong to this class of beta-specific adrenergic agonists, or you can also call them beta agonists, are the beta-2 specific agonists. There's a couple different betas, beta 1, beta 2, beta 3. These are used to manage and treat bronchospasms, asthma, and those obstructive pulmonary disorders. So your emphysemas and your COPDs and your chronic bronchitis, they're all under that umbrella. The beta 3 agonists, they're used to relax the bladder, and we use those medications for BPH and overactive bladders. The medications that are talked about in your book, they address that Isuprel, which is that sympathomimetic, which is for an overall stimulatory properties, which we're going to use in those emergency situations for shock. So we're going to talk about that medication because that's one of the most specific ones in your book. The therapeutic effects of that medication is going to be directly related to the stimulation that it has on those beta-adrenergic receptors. So the desired effects of the drug are going to be that increased heart rate. We want to increase the conductivity of the heart and the contractility. And then we want to achieve bronchodilation. We want to get that increased blood flow to the skeletal muscles and those splenic beds. And then we want to be able to use for the relaxation of the uterus. The use of this medication has decreased over the years because they've developed more specific drugs that have less toxicity to treat cardiac problems. But for the longest time, that medication, the Isuprel, was used and developed to treat those cardiac issues. And it is still used. It's just not the drug of choice or the gold standard. Your book talks about something called a coronary steal. So there's been research on that medication, the Isuprel, that it can cause a coronary steal effect in the body. So what it does is it diverts blood away from an injured or a hypoxic area of that heart muscle, an effect that can cause the increase in size and extent of an evolving myocardial infarction. So if your patient is having a heart attack, it's going to divert blood away from that injured or hypoxic area of the heart muscle, further decreasing its usefulness in the clinical setting. So it actually does the opposite. because you don't want to cause any further damage to that heart muscle. You don't want to take blood away from that injured area. You want to get blood to that heart and get rid of those hypoxic areas so you get all that nutrient-rich blood so that the heart can be oxygenated. Whoops, I missed something, hold on. Pharmacokinetics, it's going to be rapidly distributed after it's injected. It's going to be metabolized in the liver and excreted in the urine. So you're going to watch out for your patients that have liver and kidney issues. And the half-life is less than 1 hour. So it does not last very long. So the isopril is contraindicated in the presence of allergies to that drug or any components of that drug to avoid a hypersensitivity. You want to use cautiously with pulmonary hypertension because it can exacerbate the effects of the drug. You want to use cautiously with patients that are pregnant that have eclampsia, any kind of uterine hemorrhage, any intrauterine death, because it can complicate the uterine relaxation and then cause an increase in blood pressure. You want to use cautiously in pregnancy and lactation because of the effects of the fetus or the neonate. And then you want to use caution with your patients that have diabetes, thyroid disease, any kind of vasomotor problems, degenerative heart disease, or patients that had a history of any strokes, because the sympathomimetic effects on the body can be exacerbated. And then with your renal patients also, because it can alter the excretion of the drug and it can build up and cause toxicity. Adverse reaction is going to be those patients that have a reaction. It's going to be related to that stimulation of the sympathetic adrenergic receptors. So what effects would we see on the CNS? Well, we're going to see restlessness, we're going to see anxiety, maybe fear. They might just, sometimes patients will say they have like a fear of impending doom. They can't really pin anything down, but they just feel like something bad's going to happen. Cardiovascular effects, tachycardia, angina, which is that heart pain, that chest pain, an MI, which is that heart attack, maybe even some palpitations. Pulmonary effects include difficulty breathing. They might have a cough. They're going to have that bronchospasm, so they're not going to feel like they're getting enough air in. And then we can see nausea, vomiting, and anorexia, which is that loss of appetite. So you just want to use cautiously because the interactions are going to increase when you use those medications that have that sympathomimetic effect. And then you're going to have a decreased therapeutic effect with the beta-adrenergic blockers. So adrenergic blocking antagonists. So adrenergic antagonists or adrenergic blocking agents are also called sympatholytic drugs because they lyse or block the effects of the sympathetic nervous system. So sympatholytic, however you want to say it. Therapeutic and adverse effects of using these medications are usually associated with the drugs are related to that adrenergic receptor site specificity. So whatever site it's acting on. It's the ability to react with specific adrenergic receptor sites without activating them. So they react with them, but they don't activate them. And they prevent typical manifestations of central nervous system activation. They prevent norepinephrine from activating the receptor. That's how they act. And you know, there is a nice little chart for you guys to look at. It shows you the site of action for the adrenergic receptors, and then what physiological responses you're going to see as a result. And these responses are blocked by these blockers. So this is in your book. You can take a look at that. So the medications that we are going to talk about, you'll see in the clinical setting. We have carvedilol, which is also known as Coreg. We use that medication for hypertension, congestive heart failure in the adult patients. We have something called Hyalurel, which is a medication that I don't see used too common anymore. I see it from time to time. We use this in patients who have hypertension that don't respond to thiazide diuretics. And we have another medication called Ismalin, which is also for renal hypertension and regular hypertension. And then we use labetalol, which we use for hypertension, and then some patients who are going through clonidine withdrawal. The two that you're going to see all the time are the carvedilol and then your labetalol. So an easy way to remember the carvedilol and the labetalol, we'll talk about this as next semester, we're going to get into it more, but our beta blockers always, which are medications we use for hypertension, always end in AOL. And when I was in nursing school, an easy way to remember what medications were beta blockers were that they ended in LOL. We would say beta blockers laugh out loud. So that was just a way that they taught us to try and remember our beta blockers. So our adrenergic blockers, those agents competitively block the effects of norepinephrine at the alpha and beta receptors throughout the SNS. This is going to cause a result in lower blood pressure. It's going to cause a slower pulse rate and increased perfusion with decreased renin levels. So if we're going to see a result in blood pressure and a lower pulse rate, what two vital signs do you think you're going to monitor before you give those medications?
Blood pressure.
Yeah, what else?
And pulse rate.
And pulse rate. So one thing you're going to learn about these medications. And
Pulse.
Yes, very good. Pulse and heart rate. So some blood pressure medications, you're just going to monitor their blood pressure because they don't have an effect on the pulse. Things that have an effect on the contractility of the heart will have an effect on the heart rate. So sometimes you're just looking at blood pressure. Sometimes you're looking at blood pressure and pulse rate, and you'll get to know which drugs they are as you give them and you start to see patients in your clinical practice. So we're going to see low blood pressure, low pulse rate, and an increased renal perfusion with decreased renin levels. Most of these drugs are indicated to treat essential hypertension alone or in combination with diuretics. So usually when we give patients blood pressure medicines, we talked the other night that sometimes your patients get a calcium channel blocker or a beta blocker. They get different kinds of medications because their blood pressure doesn't respond to just one medication. Usually if your patient is diagnosed with high blood pressure, they give you a diuretic because diuretics decrease your circulating volume in your body by excreting it in your urine. So it makes you pee a lot. So if you have less circulating volume, then hopefully you'll have less lower blood pressure. That's not always the case. So sometimes they'll start with another drug, and if it's not effective and you've gone up as high as you can on the dose, then they'll add a diuretic on. So this is why you see more than one medication given for blood pressure, because not one just doesn't always work. So pharmacokinetics, they're well absorbed and distributed throughout the body. They're metabolized in the liver and excreted in the feces and urine. So you know what that means, right? You're going to monitor their enzymes, liver enzymes and renal function. Contraindications, you're going to use cautiously with patients that have bradycardia or heart blocks because it can worsen it. If a patient has bradycardia, which is a very slow heart rate, you would have to use your critical thinking to determine, do I want to give this medication? Sometimes if their heart rate is like in the upper 60s, so when you give medication in the clinical setting, these medications usually come with what we call a parameter. If the patient's heart rate is less than 60, hold. If the parameter could be, if the heart rate is less than 60, call the doctor to advise. But you know a normal heart rate is 60 to 100. So if your patient's heart rate is 54 and you know that this is going to affect the contractility of their heart and possibly slow their heart rate even more, and that parameter is not in there, you would want to think, let me ask the doctor, I might not want to give this medication. So we can't always depend that those parameters are in there. So this is where your critical thinking comes in, and you have to protect the patient and think about these things. You want to use cautiously with asthma because it can exacerbate the loss of norepinephrine's effect, which causes that bronchodilation, which causes the relaxation of the bronchi muscles. You want to use cautiously with shock and heart failure because it can cause worsening symptoms. And then patients who are lactating because of the adverse effects on those newborn babies. So caution should be used and exercised in patients with bronchospasms because it can progress to respiratory distress due to that loss of norepinephrine's bronchodilating action. So patients who have COPD and they have high blood pressure usually do not take any of the beta blockers, those LOLs, because it's going to further cause bronchospasms. And we don't want that because they already have that issue. Adverse reactions, dizziness. Why do you think they would have dizziness if we're slowing down, if we're treating their hypertension? Why do you think they would be dizzy? Chanel.
Can you repeat that? You said why would they have hypertension?
If we were giving them one of these medications for hypertension, so high blood pressure, why might they become dizzy? It's okay. If you say that, it's fine, you're learning. What do you think?
Is it because it's lowering the blood pressure at a rapid rate?
Yes, very good. Good job. Yes, this is critical thinking. These things are not easy to think of sometimes. So that was very good. It's going to lower that blood pressure. And sometimes people who have hypertension, they're used to living at a blood pressure at a certain level. So when it starts to come down, or if it comes down too rapidly, then they start to get dizzy. They might have that orthostatic hypotension. So that's, what do you think if you have a patient that had high blood pressure, we're giving them a blood pressure medicine, we know they're at risk for being dizzy, it might cause hypotension. What kind of education would we want to do with them for getting out of bed in the morning? What would we want to tell them?
When they first rise, to just sit there for a minute.
Yes.
And go their feet on the floor.
Yeah, and dangle the feet.
Very good. Good job. Sit on the side of the bed, rise slowly, dangle your feet there, make sure you don't feel dizzy before you stand up. Sometimes it can cause something called paresthesias, which are those numbness and tingling in the hands. It might cause insomnia, depression, fatigue, vertigo, all because all those side effects are going to be related to that norepinephrine being blocked in the central nervous system. You can see nausea, vomiting, diarrhea, anorexia, flatulence. Again, because it's the loss of the balancing sympathetic effects on the GI tract. And then you're going to see that increase in that parasympathetic system coming in. You can have cardiac arrhythmias, hypotension, heart failure, pulmonary edema. You could have a stroke, a cerebral vascular accident, all are related to that lack of stimulatory effects and that loss of vascular tone in the cardiovascular system. We could have bronchospasm, cough, rhinitis, bronchial obstruction, and then drug-to-drug interactions. Enflurane, halothane, or isoflurane are those anesthesias. So you want to use these cautiously when you're going under general anesthetics. So sometimes they might tell you if you're coming for a procedure and you are taking a medication that can cause a drug-to-drug interaction. If they know you're going to use a certain anesthesia, they might tell you not to take your blood pressure medication in the morning before you come. You want to be careful with the diabetic agents and the calcium channel blockers because of the cardiac effects that you're going to see. So some adrenergic blocking agents have a specific affinity for just the alpha receptor sites. Your book is going to speak specifically about phentolamine. So that's the medication we're going to talk about. Phentolamine blocks the postsynaptic alpha-1 adrenergic receptors. It decreases the sympathetic tone in our vasculature, which is going to cause vasodilation. Vasodilation, is that going to, if we have vasodilation, is that going to increase our blood pressure or lower our blood pressure? I want to call on someone. Don't anybody answer. Alan. If we have vasodilation, if we give phentylamine and it causes vasodilation in our vessels, is vasodilation going to lead to an increase in our blood pressure or a decrease in our blood pressure?
Increase.
No, Martha Lynn, you weren't allowed to answer. It was Alan's turn to answer.
Sorry, I didn't know that. Sorry, I'm not paying attention.
That's okay. All right. So it's going to lead, what did you say was going to happen? It's going to lead to a what? Martha Lynn, what did you say? Decrease or increase?
I thought I said going to decrease because when dilate, they're going to carry more blood flow.
Yes, it's going to make that vessel dilate, so it's going to get wider and more flow. You're going to get a bigger flow of blood through that area. So I want you guys to start making, I want you to keep reading in these books and finding out how our body's working, because this is exactly what we're going to be learning next semester. It's not going to be this knowledge-based stuff. We're really going to be learning the ins and outs on what goes on in our body. And you need to know how things work so that you can answer these questions. So yes, you're going to have that lowering of the blood pressure. So pharmacokinetics, phentylamine is rapidly absorbed after IV or intramuscular injection, and then it's excreted in the urine. And there's not a lot of information about metabolism and distribution, but we know it's excreted in the urine. So what are we going to monitor? Alan. Alan, if this medication is excreted in the urine, what labs do you think we're going to monitor? You don't have to give specific labs. What organ labs do you think we're going to monitor?
I don't know if he knows you're calling on him.
Oh. Oh, say it again.
I can see.
Yes, you guys don't know.
You don't, okay. So if it's excreted in our urine, that's okay. If you don't, actually, no, you guys are here to learn, but this is why I want to do this Socratic questioning and getting you guys to start thinking. If it's excreted in the urine, what organ in our body?
It's the kidney.
Kidney.
You're gonna monitor your BUN.
Kidney, renal function.
Yep.
Yes. So if it's excreted in the urine, Alan, we're going to want to look at our BUN and our creatinine. These are all indications of kidney function. Okay. So that was the answer. Monitor your kidney function. So anything that has to do with urine and excretion, if we say it's metabolized in the liver, that we're going to look at your liver enzymes.
AST.
Okay, your AST.
Yeah.
If we're talking about your kidney, then it's going to be your BUN, B-U-N, your creatinine, sometimes your creatinine clearance, depending. Okay? And I don't expect you guys to know this. You're learning. You don't know this. You've never been nurses before, and you're just in nursing school. So I just want you to participate and try and engage you in that critical thinking. All right, so contraindications. So phentylamine is contraindicated, obviously, in the presence of any allergy or similar drugs in the presence of any kind of coronary artery disease or a myocardial infarction, which is a heart attack, because it can exacerbate these conditions. It should be used cautiously in pregnancy or lactation. Adverse reactions, hypotension, orthostatic hypotension. Why are we going to have hypotension and orthostatic hypotension?
A decrease in blood pressure.
Yes, and what's causing the decrease in blood pressure? What's happening in our vessels? Vaso what?
Constriction. So bad. Dilation.
Dilation, you got it. Vasodilation, very good. It's very easy to get those confused. Constriction, dilation, it's hard to keep it all straight, but yes. We can see angina, which is that chest pain, an MI, a heart attack, cerebrovascular accident. You might see flushing, tachycardia, maybe an arrhythmia. These are all related to that vasodilation and that decrease in blood pressure. We can see a headache. They might be weak, dizzy, often in response to hypotension. And then we might see nausea, vomiting, and diarrhea. I mean, nausea and vomiting and diarrhea happens with everything, I feel like. So everything I talk about, it's nausea, vomiting, and diarrhea. Drug-to-drug interactions, ephedrine and epinephrine have decreased hypertensive and vasoconstrictive effects if they're taken together with that phenethylamine, because these agents work in different ways in the body. Increased hypotension may occur if this drug is combined with alcohol, because alcohol is a vasodilator. So you want to educate your patients not to drink alcohol if they're taking that medication, right? That sounds like it could be a question. Alpha-1 selective adrenergic blocking agents. So how do these act in the body? So the therapeutic effects that we see of this medication comes directly from their ability to block postsynaptic alpha-1 receptor sites. It's going to cause a decrease in vascular tone and vasodilation, which leads to a decrease in blood pressure. They also block smooth muscle receptors in the prostate, the prostatic capsule, the prostatic urethra, and the urinary bladder neck, which is going to cause relaxation of the bladder and the prostate. So if we relax the prostate and the bladder, we're going to get improved flow of urine in male patients suffering with BPH. BPH is benign prostatic hyperplasia. So the medications that we're going to talk about are prazosin, which is also mini-press. We use this to treat hypertension alone, or we combine it sometimes with other medications. We have terazosin or Hytrin, which is used to treat hypertension as well as BPH. And then we have tamsulosin or Flomax. That's the medication that I see the most in the hospital setting. And that was originally used to treat BPH, which it still does, but it's also used for the treatment of hypertension. So my father-in-law has severe cardiovascular history. He's had a quadruple bypass. He's had a heart attack at 42. He's got high cholesterol, the whole gamut, congestive heart failure, AFib. So he actually takes 4 blood pressure medications, and he just had a stroke, and they just started him on this medication to help with his blood pressure because they're having trouble controlling it. So it's important to think about these medications when you're in the room and you're giving medications next semester, and you say, Mrs. Jones, or Mr. Jones, we use it in women too who have retention. You could say, Mr. Jones, I have your tamsulosin for your BPH. And he might say, what? I don't have BPH. I don't have any problem with my prostate. Well, it's also used for blood pressure. So in that case, it would be completely okay for you guys to say, and I do this all the time with certain medications, Mrs. Jones, I have your Flomax or your tamsulosin. What do you take that for? We give that medication for a couple different things. Sometimes it's BPH, sometimes it's for urinary retention or high blood pressure. So it's certainly okay to ask your patient why they are taking it. These medications do have a specific affinity for those alpha-1 receptors. Let's see, indications, BPH and hypertension. They are well absorbed after oral administration, and they undergo extensive hepatic metabolism, and they are excreted in the urine. So what labs are we going to want to monitor?
Your buns and your creatinine.
Creatinine.
What are your liver enzymes that you're going to monitor? ALT.
Miss Davis, can I make a correction real fast?
Say that again.
AST and ALT.
Yes. What did you say, Ryan?
Can I make a correction really fast in regards to area?
Sure.
In regards to like the vasodilation, you said blood pressure would increase, but that's blood pressure would decrease. Blood flow would increase if it's vasodilating. The blood pressure would increase because the vessel's opening, so the pressure is increasing. I mean, the pressure is decreasing. I'm sorry.
So what happens is you have a decrease in vascular tone and vasodilation. If your vessels are very, very small, like only this big, okay, the force of your blood trying to get through that vessel is going to cause your blood pressure to increase. If I open it up and all of a sudden the blood flows very quickly through there and it's getting through easy, your blood pressure is going to drop. Does that make sense?
Right. So if it's vasodilating, the blood flow is increasing, but the blood pressure is decreasing.
Right.
Right. So earlier I heard someone say the blood pressure is increasing if it's vasodilating.
No, we said decrease.
No, decrease.
She said decrease. I asked her twice because I wasn't sure what she said the first time. Yes, but she said decrease.
I said decrease.
Yeah, it's hard to hear on here sometimes.
Okay, I heard increase. I was like, hold on.
No, it decreased because the vessel going to dilate and then you have too much blood flowing.
Yeah, so that's okay. I'm glad you clarified, Ryan. It's hard sometimes when there's a couple different people talking, so I'm glad you clarified.
Mm-hmm.
All right, where was I? Let me see. Okay, we said we were going to look at those hepatic enzymes, ALT and AST. ALT, AST, those are your main liver enzymes. There's a couple more, but those are the main ones we look at. So contraindications, they're going to be contraindicated in the presence of any allergy. We want to avoid that hypersensitivity reaction. They do cross the breast milk into the breast milk, so we want to use carefully with mothers who are lactating. They won't be able to take this medication. They should use cautiously in the presence of heart failure or renal failure because of the blood pressure lowering effects. It could cause an exacerbation of these conditions. Use carefully in hepatic impairment, which could alter the metabolism of these drugs. And then, of course, during pregnancy because of the adverse effects on the baby. Adverse effects are associated with their effects on the SNS blockage because they block those ANS effects. The CNS effects include headache, dizziness, weakness, fatigue, drowsiness. Those GI symptoms we're going to see are nausea, vomiting, abdominal pain, and diarrhea. Cardiovascular effects, you might see arrhythmias, hypotension, edema, heart failure, and angina. The vasodilation caused by these drugs can also cause flushing, rhinitis, reddened eyes, and sometimes some nasal congestion. Drug-to-drug interaction, increased hypotensive effects may occur if you combine these drugs with other vasodilating or antihypertensive drugs, such as certain nitrates, calcium channel blockers, drugs that we use for erectile dysfunction, and then those angiotensin converting enzyme inhibitors. And you're going to learn all about those next semester, more than you ever wanted to know about them. All right, so the beta-adrenergic blocking agents, these are used to treat migraine headaches and cardiovascular problems such as angina and hypertension. And we use them to prevent recurring heart attacks, myocardial infarctions after they've already had one. The medications that you will see used are Nadolol, or it's also called Corguard. You might see Bastolic. Bastolic is a very new medication that has not been out that long. You might see Sotalol, where also it's called Beta Pace, and then Timolol. Those are the common medications that we see. The therapeutic effects of these drugs are going to be related to their competitive blocking of that beta-adrenergic receptor in the sympathetic nervous system. The blockade of the beta receptors in the heart and in the juxtaglomerular apparatus, I hate these words, of the nephron is going to account for the majority of the therapeutic benefit. So that's where it's going to take place. It's going to cause a decreased heart rate, decreased contractility and excitability, as well as membrane stabilizing effects, which is going to lead to a decrease in arrhythmias, a decrease in how hard the heart has to work. We call that the decreased cardiac workload. So how hard is that heart having to work to get that blood out? It's going to decrease the effect. And then it's going to decrease the oxygen consumption that we need. The effects are useful in treating hypertension and that chronic angina, and it's going to help prevent that a reoccurrence of a heart attack by decreasing the cardiac workload. These drugs are absorbed from the GI tract after they are administered orally, and they undergo metabolism in the liver. They're contraindicated in the presence of allergy to any known components of the drug. You want to use cautiously with bradycardia, heart blocks, shock, or heart failure because it can exacerbate these symptoms. Cautiously with bronchospasm and chronic obstructive pulmonary disease, COPD, and then acute asthma because it's going to worsen those effects due to the blocking of the sympathetic bronchodilation. These drugs should be used cautiously in patients with diabetes and hypoglycemia because what they do is they block the normal signs and symptoms of hypoglycemia and hyperglycemia. So hypoglycemia is low blood sugar, hyperglycememia is high blood sugar. So they wouldn't have the normal, if someone was having a low blood sugar, they might not have the normal signs and their blood sugar could progress to an even lower number, and they could be unconscious. It could happen when they're driving. They could have a bad reaction. And then you want to use careful with your renal and your hepatic patients. Patients receiving these drugs often experience adverse effects related to the blockage of the beta receptors in the SNS. This includes headache, fever, dizziness, depression, those paresthesias, sleep disturbances, memory loss, disorientation. Those are the CNS effects we're going to see. The cardiovascular effects are going to include bradycardia, heart blocks, heart failure, hypotension, peripheral vascular insufficiency. Pulmonary effects are going to be, you might see difficulty breathing, coughing, bronchospasms, all the way up to severe pulmonary edema and bronchial obstruction. GI symptoms, nausea, vomiting, diarrhea, gastric pain, and it could even cause colitis. And then those GU effects, decreased libido, impotence, and dysuria. Beta-adrenergic blocking agents, what kind of drug-to-drug interactions would we want to avoid? So there is something called paradoxical hypertension that occurs when beta blockers are given with clonidine. Clonidine is one of these medications that we talked about, and it causes an increased rebound of hypertension with clonidine when they stop taking it. So you just want to avoid that combination altogether. A decreased antihypertensive effect can occur when beta blockers are given with some certain non-steroidal anti-inflammatory drugs, those NSAIDs. When you combine those drugs together, sometimes you have to use them together. You need to use the beta blocker and they have to have an NSAID for whatever reason. You just want to make sure that you are monitoring them closely so that you make sure that you can achieve the desired blood pressure control that you want. And then when these drugs are given with insulin or other anti-diabetic agents, there's a potential for a change or a quick change in those blood glucose levels. And then those patients aren't going to see the usual signs of hypoglycemia or hyperglycemia. So you want to educate them about that. All right, so what is the advantage of using these, the beta ones? They don't usually, the beta 2 receptor sites, including the, so the advantage, sorry, I said that wrong. The advantage to using the beta 1 selective adrenergic blocking agents, they don't usually use the blocker 2 receptor sites, including that bronchodilation. So these are preferred drugs for people who smoke or have asthma, who have COPD, emphysema, or any kind of seasonal allergy, any regular asthma, or any kind of allergic rhinitis. They would be able to take these medications because they don't use, they don't affect that beta 2 receptor site. And we can use it also with hypertension, certain cardiac arrhythmias, and that angina, which is the chest pain. So beta 1 selective adrenergic blocking agents, they have an advantage over non-selective beta blockers in certain instances. We said that they don't block the receptor 2 sites, so you're not going to see that sympathetic bronchodilation, which is important for the people with lung diseases and then allergies. These medications that you'll see, atenolol, also named tenormin, and then metoprolol, also called low pressor or toprol XL. How these work in the body, they work, the effects that we see are going to be related to their ability to block that beta 1 receptor site in the SNS at the therapeutic doses that are prescribed. As a result, they're not going to block the beta 2, and therefore they do not prevent the sympathetic bronchodilation. So they are absorbed from the GI tract after oral administration. Metoprolol, the bioavailability of metoprolol in the body is going to be increased if it's taken in the presence of food. The drugs are going to be metabolized in the liver and excreted in the urine. Metoprolol, unlike the tenormin, will cross the blood-brain barrier and can cause more CNS effects than the atenolol, because the atenolol does not cross that blood-brain barrier. Contraindications would be allergies, if you have sinus bradycardia, a heart block, if you're in cardiogenic shock, if you have heart failure, hypotension, all which would be exacerbated because we're giving a medication that depresses the cardiac system and lowers that blood pressure. They should be used in caution with patients with diabetes and thyroid disease because of that, the adverse effects on the sympathetic blockade system. The CNS effects include headache, fatigue, dizziness, depression, paresthesias, sleep disturbances, memory loss, disorientation. Cardiovascular effects include bradycardia, heart block, heart failure, hypotension, vascular insufficiency. Pulmonary effects, we're going to see that rhinitis. We could see bronchospasm and dyspnea. GI upset, we're going to see nausea, vomiting, diarrhea. Patients may complain of gastric pain, even colitis. GU effects, decreased libido, impotence, and dysuria. So a decreased hypertensive effect is going to occur if we give these medications with clonidine, any NSAID, rivampin, or certain barbiturates. So you want to be careful to stagger your administration of those medication. And then increased serum levels and increased toxicity of intravenous lidocaine can also occur with certain of these medications, with certain ones. We're almost done, guys. Anticholinergic agents. So you will have a couple questions about anticholinergic agents on your exam. What are they? They are drugs that oppose the effects of acetylcholine at the acetylcholine receptor sites. Atropine is one of the most used medications that is an anticholinergic drug. We use atropine to depress salivation and bronchial secretions, and it helps dilate the bronchi. So it can also thicken respiratory secretions, which causes obstruction of airways. Atropine is also used to inhibit vagal responses in the heart, to relax our GI and GU tracts, to inhibit GI secretions. It causes mydriasis. Mydriasis is relaxation of the pupil of the eye. Scopolamine is another medication that we use. This acts more specifically on the receptors in the GI tract, and they are used as adjuncts in treatment of peptic ulcers. Sometimes you'll see it with irritable bowel syndrome, certain GI disorders. Sometimes you have a patient that goes off your floor and they'll have general anesthesia, and when they come back, they'll have a scopolamine patch, little baby circle that goes right behind the ear on the back of the head there, and it helps decrease their nausea and vomiting. Sometimes if you work on oncology, you can also administer them to your oncology patients because it helps take care of their nausea and their vomiting. We also give oxybutynin chloride. Oxybutynin, this is another medication. This helps relax the bladder and the ureter, and we use it to treat overactive bladder and certain bladder spasms. So because of, we said it lyses or blocks the effect of the PNS, or the parasympathetic nervous system, they're also called parasympathiolytic agents. This class of drugs was at one time widely used to decrease GI activity and secretions when we treated patients with ulcers, to decrease that parasympathetic activity and to allow sympathetic systems to be more dominant. Today, they have more specific and less systemically toxic drugs that are available to treat these conditions that have less side effects. Usually they are not anticholinergic drugs. The drugs are not tolerated due to the side effects. They can be pretty unpleasant. So atropine is a prototype drug. It's been used for many, many years, and it is derived from a plant called the belladonna. So just a little fun fact, belladonna was used at one time, way back when, in the European countries by what they considered fashionable ladies to dilate their pupils because they wanted to look more innocent and alluring for their men. So they would dilate their pupils. It works by blocking the muscarinic effectors in the parasympathetic nervous system and the few cholinergic receptors in the sympathetic nervous system. So it affects both para and sympathetic nervous system. It acts by competing with acetylcholine for the muscarinic acetylcholine receptor site. They do not block the nicotinic receptors, and therefore they have little or no effect at what we call the neuromuscular junction. So what effects will we see? We're going to see an increase in heart rate. We're going to see a decrease in GI activity. We're going to see a decrease in urinary bladder tone and function, and we're going to see pupil dilation. Sometimes we give these medications in eye drops because we want to dilate their eyes. This is a great little chart that I added for you guys. You probably don't have it on yours because I didn't have it on mine, but I added it. So this tells you all about the physiological effects and the therapeutic uses for our anticholinergic medications. So you'll see here in the urinary tract, it decreases the tone and motility in the ureters and the fundus of the bladder. So it increases the tone in the bladder sphincter. So it's going to increase their bladder capacity. It's going to decrease spasticity. It decreases urinary urgency and frequency with cystitis. And it's an antispasmodic. So we might give this to patients that have UTIs. We might give this to patients who have urinary and frequency issues all the time. And then here it also says that we use this medicine to counteract bladder spasms caused by morphine. Remember in the beginning part of this lecture tonight, we talked about morphine and those narcotics and how it can cause bladder spasms sometimes. So this might be a medication you give if your patient has to take morphine for some reason. So this is a great chart. We see down here, we have ocular effects. It causes pupil dilation, right? So it allows the ophthalmologic examination, it allows that ophthalmologist to be able to look inside and observe the retina, the optic disc. It relaxes ocular muscles and decreases irritation. So you can have that eye exam and that ophthalmologist can see all the important parts of the eye. So this is a good chart to know. So anticholinergic drugs. Whoops, I lost my slide. Hold on a second. All right, they block the acetylcholine receptors. At the receptor site, they decrease secretions. They restore cardiac rate and blood pressure. It blocks parasympathetic effects in many situations. It dilates the bronchi, inhibits vagal nerve responses. One medicine that we see is dicyclomine. It's also called Dibent. We use this to treat hyperactive or irritable bowel. It helps relax that GI tract. Sometimes we use something called Robinol, which is used in the treatment of ulcers. And then we use something called Probathine, which also is used for ulcers. It is used for pylospasms and hyperbowel activity. So sometimes you have a spasm in where the pyloric sphincter is in the stomach, and it'll just keep spasming and opening up, and then the food will come back up again. So you can use the medication for that. And then it relaxes that uterine hypertonicity. So it's gonna help with that help decrease that urgency and frequency. They are well absorbed, well distributed throughout the body. They cross the blood-brain barrier. Half-life is based upon the route that you're giving and the drug itself, and it's excreted in the urine. Contraindications would be any condition or medication that you had an issue with earlier that would cause a hypersensitivity or an allergy. Use carefully with glaucoma because it can increase intraocular pressure with that pupil dilation. And with glaucoma, they already have an increased pressure in their eyes, so you don't want to keep increasing it. They can lose their vision. Any condition that would be exacerbated by the blockade of the parasympathetic nervous system. Any kind of peptic ulcers, paralytic ileuses, GI obstructions, any kind of ulcerative colitis, it's going to further exacerbate that issue. And then patients with prostatic hypertrophy and bladder obstruction, it can be further compounded by a blocking of the bladder muscle activity and blocking of that sphincter relaxation in the bladder. Anticholinergic drugs. So the adverse reactions, we can see that mydriasis, which is the dilation of the pupil. We can see cytoplegia, which is a paralysis of the ciliary muscle of the eye, which results in a loss of accommodation. So blurred vision, photophobia, palpitations, bradycardia, dry mouth, altered taste perception, urinary hesitancy, retention, sweating, and predisposition. So it's going to cause decreased sweating, which is a predisposition to heat prostration. So it is when your body is overheating. So you would not want to use this because if it causes decreased sweating, your body wouldn't be able to react. So if you took this medication and you were a roofer and you worked outside, that would be a bad combination because he wouldn't be able to sweat, which means that he wouldn't be able to cool his body down if he was overheating. Okay, so you have to be careful. The incidence of anticholinergic effects increases if these drugs are combined with certain other drugs that have anticholinergic activity. These are your antihistamines, your anti-Parkinsonism drugs, your MAOIs, your tricyclic antidepressants. If you have to use these drugs combined together, you want to make sure they're being closely monitored, that they know certain side effects, and that their dose adjustments are made by their physician. You also want to advise your patient to try and avoid over-the-counter medications that contain these drugs. The effectiveness of those phenothiazines, which remember we give for certain mental and emotional disorders like anxiety, depression, and schizophrenia. The effects of that medication is going to decrease if you combine them with anticholinergics. And then there's a risk of a paralytic ileus. So you should avoid that combination. Okay, so just some key points. I don't think you guys have this slide, so I'm going to add it for you guys to look at. So at the cholinergic receptor sites, anticholinergic drugs block the effects of acetylcholine. Because they block the effects of the parasympathetic nervous system, that's why they are called parasympatholitic drugs. When the parasympathetic nervous system is blocked, the pupils dilate, the heart rate rises, and GI activity and urinary bladder tone and function decrease. So you need to know your CNS system, you need to know your PSNS system, and you need to know how what's going to be affected by certain medications, okay? I'm going to want you to answer, we're going to answer some questions tonight, but I want you guys to know how these drugs affect those systems and how to critically think with your patients. I'm not going to ask you a question that is going to ask you to tell me what the parasympathetic nervous system, what side effects we would see. I'm going to put it into a question that's going to present with a certain patient, with a certain medication, with certain symptoms, and you're going to have to try and revert back to your knowledge to figure out what things you would want to monitor. That's your critical thinking, okay? So let me see, I do have a couple, these aren't all questions from tonight, actually. These are just questions from, just kind of like a review from what we've done already. If you don't want to stay on, you don't have to. I know it's past 8 o'clock. Oh God, something's happening. Can you guys see that? I don't know what's happening. The whole thing's moving. All right. I'm not sure what's happening. Let me try and pull it up again. All right, let me try and move it over again. There we go, that's better.